Good morning, everyone. Thank you for the Sarawak Heart Center for the kind invitation. My name is Feng-Jung from the Department of Medical Genetics at National Taiwan University Hospital. Let me set the frame for the next hour. This is a talk about finding Fabry disease early and about what nearly 2 decades of newborn screening in Taiwan can offer a heart center here. Here is the roadmap for the hour. We begin with why early identification matters, that biology that makes Fabry a cumulative substrate-driven disease with a treatable window. Second, how to diagnose, how to screen, and how to treat, and how many advance in these 3 years, and lesson to Sarawak and Malaysia. Let us begin with the fundamental, what the disease is, why it happens, and why finding it early change the outcome. The key idea threaded through this whole block is the damage is cumulative and substrate-driven, so there is a window in which treatment generates out the trajectory. Fabry disease is an X-linked inborn error of metabolism. The GLA on the S chromosome encoded the lysosomal enzyme alpha-glycosidase A. When the enzyme is deficient, its substrate GB3 or GL3 accumulates progressively inside the lysosome through the body, particularly in vascular endothelium, kidney podocyte, cardiomyocyte, and the neuron. The deacylated water-soluble form lyso-GB3 circulate in plasma and is both toxic and a very useful biomarker, as we will see. Two teaching points. First, Gaucher disease. This is the most common lysosomal storage disease. Second, please emphasize to the training because it's X-linked. Males are hemizygous and typically more severely affected, but females are not simply a symptomatic carrier. Owing to randomized X inactivation, a heterozygous woman can be as severely affected as a man. This slide places the disease in historical and mechanistic context. Fabry was first described in 1898, independent by Anderson in England and Fabry in Germany, as angiokeratoma corpus diffusum. It took until the 1960s to recognize it as a sphingolipid storage disorder and to establish its X-linked inheritance. Mutation in the GLA gene leading to a deficiency of alpha-GLA activity, so the GL3 and the lyso-GL3 was accumulated in cell. Cell become organ, become systemic damage. Fabry disease comes from 4 steps. First, a pathogenic GLA variant produces deficiency or absence of alpha-GLA. Then, the substrate GB3 and its circulation form lyso-GB3 accumulate in lysosome. And it is not an inner storage. It's a cell injury. It triggers endothelial dysfunction, a chronic inflammation, and a poor fibrotic response and poor thrombotic status. Over years, organ damage. It produces 3 organ systems that determine prognosis: kidney, heart, and the brain. The single most important practical message is in the bottom. The injury is cumulative, substrate-driven, and once fibrosis is established, it's irreversible. This is an entire rationale for diagnosis and treatment early, and for following lyso-GB3 is a good marker of disease burden and treatment response. Fabry disease is not one disease, but a spectrum. The classical phenotype occurs in males and essential no inactivity. It begins in childhood with neuropathic pain in hand and feet, together with reduced sweating, heat intolerance, reddish angiokeratoma. Renal cardiac CNS disease follow in adulthood. The later onset or non-classical type increase in recognize. This patient retains some residual enzyme and present in adulthood, often with disease confined to one organ. The cardiac variant with left ventricular hypertrophy and arrhythmia. Renal variant with proteinuria and progressive CKD. Because it is look like single organ, it repeat mislabeled as idiopathic. Finally, the message in the dark band is the one nurse physician most often get wrong. Women are not merely carrier. Female are not just carrier. Random X inactivation means a heterozygous woman can be just a effective carrier, maybe a asymptomatic carrier. Here is the whole disease in one slide, organ by organ. The three colors in coral on the top row: renal, cardiac, and CNS. Renal disease progresses from proteinuria to end-stage kidney disease. Cardiac involvement gives left ventricular hypertrophy, diastolic dysfunction, arrhythmia, and conduction disease. And now is the leading cause of death. CNS disease causes early stroke and transient ischemic attack, often in the posterior circulation. The low row holds the early, so cool. The burning sensation in hand and feet, reduced sweating and heat intolerance, eyes, corneal problem, and angiokeratoma. The other useful sign is GI symptom. The GI symptom, abdominal pain, diarrhea are frequently dismissed as an irritable bowel. When you see the early stroke, unexpected left ventricular hypertrophy and proteinuria, think about Fabry disease. This is the same message from multiple system disease organ by organ. Kidney, heart, brain is life limited system. Skin, eyes, and sweating is early clue for think about Fabry disease. Hypohidrosis, cardiovascular involvement, and polyneuropathy, and renal involvement, GI symptom. Think about Fabry disease. Fabry disease deserves special attention in Taiwan. Newborn screening Taiwanese infants reveal a high prevalence of cardiac variant intronic mutation IBS4 plus 19G2A, roughly 1 in 1,600 newborn males, and the single variant account 82% screen pass baby. With the same investigator screened the man carrier label of idiopathic hypertrophic cardiomyopathy. About one quarter were actually IBS4 Fabry patients. The variants cause a late onset, predominant cardiac phenotype. Carriers are typically well until adult and develop LVH or arrhythmia, and interesting, a usual male-female difference in age of onset is blunted. The practical bottom line of everyone in this room in Taiwanese adult as well, we come to Chinese ancestry adult anywhere with unexplained left ventricular hypertrophy, arrhythmia, and all proteinuria. Fabry disease is not a zebra. Test for it. Fabry disease has many GLA mutations. Phenotype tracks with genotype. On the left, variants that abolish the enzyme entirely. Nonsense frame shift large deletion gives the classical multi-organ phenotype without any residual activity. Missense rare splicing variants leave some residual alpha-gal activity. The residual activity is what produces the mild late onset phenotype. Our Taiwanese founder variants IBS4 plus 90G2A sits exactly the residual activity zone, which is why it presents late and predominant in the heart. And the far end, benign polymorphisms and the variants of uncertain significance are the reminder that not every GLA change is disease causing, which is where lyso-Gb3 and family data help us to decide. Now, how we are actually make a diagnosis and why the strategy differs by sex. Male and female needs different first tests in Fabry disease. The most common diagnostic error in Fabry disease comes from forgetting that the workup is sex-specific. In a man, major alpha A enzyme activity in plasma, leukocyte, or conveniently on a dry blood spots, a low and absence enzyme activity is essentially diagnostic in male. Then you confirm with GLA sequence with identify the pathogenic variant, which you need both for family screen and to determine the oral chaperone megastate is amenable or non-amenable. Female, the rule is different. Enzyme activity is unreliable, so you must, based on the family history, you need to order GLA sequence. So GLA molecular testing is mandatory. Genotype is the gold standard. Biomarker, especially plasma lyso-Gb3, are become central to Fabry practice. Lyso-Gb3 is the isolated circulation form of the stored substance. It has 4 roles. It supports the diagnosis when elevated. It is particularly helpful in heterozygous women where enzyme activity is equivocal. A markedly rise level provides strong evidence that the GLA variant of VUS is pathogenic. It falls with effective enzyme therapy, so it can be treat monitoring. Besides lyso-Gb3, plasma and urine Gb3 also helpful. Besides the biomarker, renal biopsy is gold standard when seen with classical zebra body in the electron microscope. The caveat in coral is important here. In late onset and cardiac variant disease, including our common IVS4 variants, lyso-Gb3 may be only mild elevated, so nearly normal value do not exclude the disease. Always read the biomarker together with the genotype and the clinical picture. This slide is come from Professor Yixiu Jian. It divides 2 parts. One is alpha-gal activity. One is lyso-Gb3. Male with IVS4 is green dots. Female with IVS4 is purple dots. The female cannot pick up by GLA activity, but lyso-Gb3 can pick up female. Screen negative is below 0.8. Screen positive IVS4 is above 0.8. The classical variant carrier can above 0.8, and the male either classical or IVS4 is above 0.8. So the lyso-Gb3 can be diagnosed in both gender and monitoring in male. Once the diagnosis confirmed, the disease must be mapping across organ before treatment because therapy decision and molecule depends on the baseline. Renal assessment means major EGFR, UPCR, consider renal biopsy if atypical. Heart, ECG cardiac MRI with T1 mapping and left gadolinium enhancement for early fibrosis disease. Brain, MRI for white matter lesion, sinus infarction, stroke risk assessment. eyes and skin for the Fabry sign. The skin angiokeratoma must be recorded. Neuropathology evaluation and recruit to your study, just like a registry in your country. This is a practical diagnostic algorithm. It starts with clinical suspicions, and the triggers are listed across the top. Unexplained LVH, early crypto stroke, proteinuria, CKD of unknown cause, aquaparesthesia with angiokeratoma, positive family history. Sex are different in the next step. Male, major alpha-KOA activity in plasma or dry blood spots. Low and absent NI activity, you should confirm by GOA sequence. If no more NI activity, Fabry disease can totally exclude. Female, GOA sequence is first line. Do not rely on the NI activity. Often normal. Pair with the lyso-GB3 with clinical assessment. Once a GOA variant is confirmed, two things happen. Confirm GOA variants, you should do baseline multi-organ workup, renal, cardiac, CNS, staging the disease, and the treatment decision. Cascade family screen after genetic counseling, target sequence for the at-risk family in the pedigree. Screening is where Taiwan leads the world. We have two official associations to do. One is nephrologist, one is cardiologist. This first algorithm is published from Taiwan Society of Nephrology. It from Lin and me in 2024 is the workflow to find Fabry disease in CKD population. This is two design features. First, it diverges by sex at the diagnosis step, and then lead in male, genotype lead in female. Second, it carries cardiac reflex sign overlay. A CKD with LVH show PR interval, conduction disease, a low native T1, that gadolinium enhancement should move up your suspicion list. In a renal clinic, this is in fact a ready-made screen protocol. These slides carry one of the most sobering numbers in the field. This comes from Taiwan Society of Cardiology consensus for Fabry disease. It points out the delayed diagnosis in patients with Fabry disease. Roughly 50 to 20 years of delay in diagnosis after symptom onset in both sexes might lead treatment delay. Men with Fabry disease without treatment may have a shorter lifespan than general population, approximately 50 years. Untreated women may live to around 70 years, which is considered shorter than the general population. Newborn screen report high prevalence of our IVS4. It's a very special situation in Taiwan. This algorithm is proposed by Taiwan Society of Cardiologists. The flowchart and reflex signs for the diagnosis of Fabry disease in patients with idiopathic unexplained LVH. They trigger the Fabry testing are listed here. A short PR interval, conduction abnormality, and MRI abnormality, just like low native T1 and late gadolinium enhancement. with the cause of any neuropathic kidney and family clue. In a man, that means an enzyme assay. In a female, straight to the GLA sequencing. This slide answers the natural question: how often will I actually find it? This 2023 fully analysis of Fabry prevalence across high risk and newborn screening. The meaningful in exact cohort you see unexplained LVH hypertrophic cardiomyopathy. Conduction disease is high prevalence. The other is small fiber neuropathy, CKD, and stroke, and newborn screen. They just a screen reflex. Taiwan pioneered nationwide newborn screen for Fabry disease. The model is elegant. The same dry blood spot used for the other newborn metabolic screening is assayed for alpha-gal activity. A low result trigger reflex genetics. Because the common Taiwanese variant is the late onset cardiotype, screen many identified baby who would otherwise have suffered decades later with LVH and arrhythmia, give us a chance to monitor and intervene before irreversible damage. Beyond newborn screen, there are two further screen strategies. The first is target screen of high-risk population, patients already in our cardiology, neurology, and nephrology. Screen male with unexplained LVH, hypertrophic cardiomyopathy, young and crypto stroke, unexplained CKD, and dialysis. The second is family cascade screening. Conduct a third-generation pedigree from every index case. Offer genetic counseling, target GLA2 family at risk. Test the at-risk female by genotype, not enzyme level. Identify pre-symptom relative. Enable timely treatment before organ damage. Now, let's go to the treatment, the part that makes early diagnosis worthwhile. There are now 4 disease-specific therapy. 3 are enzyme replace therapy given intravenous every 2 weeks: agalsidase alpha, agalsidase beta, and the newer pegylated pegylated galsidase alpha. The fourth is migasidase, an oral pharmacological chaperone that is only suitable for patients with GLA variant is amenable. But the principle in the drug: treat early before irreversible fibrosis, personalize the choice to the phenotype and the organ involvement, combine disease-specific therapy with supportive care, monitor response by EGFR, cardiac image, lyso-Gb3, manage the patient with multiple disciplinary team is very important. Enzyme replacement therapy has been backbone of Fabry treatment for over 2 decades. The principle is very simple. Infuse recombinant alpha-GLA intravenous every 2 weeks to clear Gb3 from vascular endothelium and other tissues. Randomized control study showed 69% of treated patients clear renal microvascular endothelium Gb3 deposit at 20 weeks, then control. Benefits are greatest when start before advanced organ damage, stabilize renal, cardiac, neurological cause, and improve GI symptoms and quality of life. Infusion-related reactions are very common. Pre-medication and monitor. Most patients seroconversion to have anti-drug antibody. Neutralized antibody can blunt the efficacy, especially in classical male. Lifelong, every 2 weeks, adherence venous access matter. Home infusion is an option. Tracking EGFR, proteinuria, cardiac image, and lyso-Gb3 over time. Migaste is conceptually different from ERT, and it is a first oral option. An oral small molecule that bind, stabilize specific mutant alpha-GLA, improve its folding and trafficking to the lysosome, only for amenable missense GLA variants. Amenability is determined by a validated in vitro assay. Not all variants response, and the real-world amenability of some variants is the best. Oral every other day, no infusion reaction. The evidence comes from 2 studies. In amenable patients, stable renal function over follow-up, and the reduction of ventricle mass index, particularly when LVH was present. GI symptoms also improve. At selection point, only GLA amenable can use. Neurologic effect are not well studied. ERT should be performed for some pain phenotype. Disease-specific therapy is only half the job. The other supportive care address organ complication, just renal protection, cardiac care, stroke prevention, pain management, GI and supportive care, MDT and nursing. Not in one word, treat as diabetes. Renal protection usually use ACI, ARB for proteinuria, blood pressure control, metabolic control, nephrology follow-up, cardiac care, manage arrhythmia, heart failure, anticoagulation device may be indicated. Stroke prevention, antiplatelet therapy, vascular risk factor management, pain management, GI, supportive care, and multiple disciplinary treating care. Let's talk about recent advance. The first major advance is a second-generation NI therapy, pegloticase alpha, approved in 2023. It is a pegylated recombinant alpha-gal with a longer circulation half-life, potentially low immunogenicity. The key evidence is a balanced trial, a 2-year phase 3 head-to-head comparison against agalsidase beta, the strongest comparator. It enrolled adults with already on ERT but still lost renal function. The result is pegloticase alpha was non-inferior to agalsidase beta for the rate of eGFR decline. Another, the pegylated form have fewer mild, moderate infusion-related reaction and lower neutralized autoantibody than agalsidase beta. The second strain of recent advance is substrate reduction therapy, a fundamentally different and oral approach. Instead of replacing the missing enzyme, you inhibit enzyme to cut down the GP3 production at the source. But the trial did not meet the primary endpoint in neuropathic pain and renal function, so it was not yet proven any clinical benefit now. The most exciting frontier is gene therapy. The goal is one-time durable correction that could replace lifelong infusion, but status under investigation and promising. Not yet become standard of care. Serious adverse events have been reported even with approach considered safe. Long-term safety and durability data are still question mark. Beyond approaching drug and gene therapy, several strategies are emerging. Substrate reduction therapy use oral agent to cut GB3 production upstream and now under clinical investigation. Next generation engineer enzyme and mRNA-based delivery alpha-GLA are in development. On the diagnosis side, a beta biomarker lyso-GB3 isoform cardiac T1 mapping proteomics to detect early stage. Early tail therapy treat pre-symptomatic screen detect patient, match drug and genotype and organ profile is now developing new treatment policy. The unified theme, diagnosis earlier, treatment earlier, and personalized therapy to genotype and organ involvement. The pipeline is rich, but the biggest near-term gains still come from recognized Fabry disease in the patient already sitting in our clinic. So we must treat early before fibrosis. We have spent most of this hour in Taiwan. Now let me bring it home to this room. The question is not whether Sarawak should copy Taiwan's newborn screening program. That is a major national undertaking. The question is which of Taiwan lessons you can use right now and the patient infrastructure you already have. And the headline, which may surprise some of you, is the Fabry is not a textbook here. It already been here. It already found in Sarawak. A quick orientation to Malaysia because context sharp strategy. About 36 million people split between Peninsula Malaysia and Eastern Malaysia on Borneo, Sabah, and Sarawak, which together are around 60% of the land area but sparsely populated. The geography is the single biggest practical barrier here. Distance makes anything hard. The population is multi-ethnic. Importantly, around a fifth is ethnic Chinese, which matters because Taiwan found the effect variant. The other thing is Malaysia is upper middle income countries with a dual public-private systems, so their physical capacity but high cost of drugs still demand carefully. What is the profile in prior Fabry care? Aging, rising CKD, cardiovascular disease, the very organ Fabry target. Eastern Malaysia geography, distance, hampered referral, and specimen transportation. Ethnic diversity, 20% Chinese population make Taiwanese IVS4 founder variant worth working for. Affordability, high cost of drug make higher target screen to the regional strategy. So it's the special situation for Malaysia. The first two reported Fabry disease cases in Malaysia was both from Sarawak. One fellow in meaning one fellow in Kuching. Published in 2021, Index Family 1 is a patient with nephrotic range proteinuria and eyes problem carrier, a GLA missense variant. It's a classical variant. There were start with oxidase beta, developed no neutralized antibody after 2 years. The kidney function stabilized, while the same variant relative are asymptomatic till now. Index family G2 is culturally tail, a man already on dialysis in with end-stage renal disease, with prior headache and seizure, residual inactivity, and a normal lyso-GB3, carrier a novel GLA variant. The combination is exactly the late onset trap we discussed. Normal enzyme but normal biomarker. do not exclude Fabry disease. These next two slides are taken from the report. The first two Malaysia cases on record. The index case 1 is 39 years old. Index case 2 is 62 years old. Tied to the first symptom until diagnosis is 9 years in case 1, 4 years in case 2. The residual GOA activity is 0 in case 1. Still have residual enzyme activity in case 2, but the lyso-Gb3 was increased in both cases. Case 1 is a classical genotype. Case 2 is a VUS, is an unknown genotype, a de novo genotype. The cardiac involvement we can see in the case 1. The important thing is hypertrophic cardiomyopathy in both cases. The intraventricular wall thickness was about 10 mm. Both has the LVH. ERT was used in case 1, so case 2 will not use ERT because dialysis and the late onset cardiac variant. This is the result of family screen and the pedigree from index patient 1 and 2. Index case 1 is male. He have X, Y. X pass to daughter. The daughter's lyso-Gb3 was increased, but the enzyme activity cannot reliable. The case 2 is a VUS, is late onset, so the enzyme activity still have lyso-Gb3 increase a little bit, so the chromosome X chromosome passed to his daughter. The daughter see the lyso-Gb3 was 1.3. Residual enzyme activity is 4.4. This means the GOA activity is not reliable. So the family screen and the pedigree from the index patient, you can pass from the X chromosome to daughter, but to his son, he doesn't pass to his son. Over 2 decades, Taiwan built up a mature ecosystem. Nationwide newborn screening, established treatment center, reimbursement lifelong therapy for rare disease, national rare disease framework, strong genetic counseling capacity now established. In Malaysia, now in early stage, newborn screen not including Fabry disease. Treatment center few and concentrated. Reimbursed therapy variable. Rare disease framework under development. Genetic counseling limited reach. So the outcome depends on systemic scaffolding, not just a science. It's important nationwide to take over the responsibility to rare disease care and have a budget to develop a good lifelong therapy for Fabry disease. So what Sarawak Heart Center actually can do? 6 steps to early identification. The first is high-risk cardiac screening. Screen for unexplained LVH, hypertrophic cardiomyopathy clinic, highest year rate in heart center. Second, renal and stroke screen. Renal add on explain CKD, dialysis, neuro, young, and cryptogenic stroke cohort. They can do early identification. Third is family cascade testing. For every index case, the highest rate, the low-cost intervention for all. The other is build diagnostic capacity. Alpha-GLA assay, lyso-Gb3 assay, GLA sequence with clear reference pathway. Fifth is link to treatment center. Design and connect a center of expertise for multidisciplinary lifelong care. The sixth part is most important part is financial awareness, reimbursement against realistic clinical prevalence, sustained clinical education is the opportunity. After this class, I hope everyone be one of a kind in a rare disease. You increase awareness in your field. If you face unexplained LVH, cardiomyopathy, hypertrophic cardiomyopathy, conduction disease, unexplained CKD, early age stroke, cryptogenic stroke, you think about Fabry disease. 2 years ago, I go to Kinabalu. I climbed in April 2024. It's a very beautiful place I've ever been in Malaysia. I certainly come home with Sabah, a rich man. The little crab give me away why. In Mandarin, a crab claw is 有钱人. So if you ever want to get rich, the secret is simple. Visit Sabah, buy the crab. Thank you for your attention and for the opportunity to present here at the Sarawak Heart Center. I am very happy to take questions on any part of today's talk. 欢迎大家提案讨论，有任何问题可以写信给我，我们再一起讨论。